Hello, everybody. Thank you so much for surviving until the end of the day. So thank you so much for the introduction. My name is Marta. I'm one of the emergency and critical care residents at the Ralph. And in a very, very brief way, we're going to have a very quick look into the new adult and newborn resuscitation recovery guidelines. My first question to you is, by showing of hands, who has done CPR in their lives? This is a room of professionals. Thank you. Welcome. And also to newborns in terms of cesareans and everything else, how many have the whole room? So you will all know this by heart, I'm pretty sure. And my final question is, how many of you found it very stressful to do this? Or they think it's very chaotic, it thinks that everyone is rushing? No, very good. So the plan of going and looking into these guidelines is actually to make this event as calm and as least stressful as possible, with the final aim of basically improving the outcome of something very drastic and dramatic that has just occurred to our patients. We're going to go for a few points regarding of how to be prepared and be aware for when unfortunately a cardiopulmonary arrest happens to our patients, either when they come through the door or to the patients that are under our care, and as well the importance of the early recognition a cardiopulmonary arrest and when to start our CPR, the key aspects of basic life support, which is basically the core of CPR, the measures that we use with advanced life support to aid that, the importance of debriefing and how that actually improves the outcomes of the patients, and then we're going to dwell a little bit in how we can also do that in the newborn population. So, being prepared and being aware. Are people aware of what is recover and what are the guidelines by show of hands? Do people have heard of this? Quite the majority. So I will invite you, if you haven't heard or if you only have a glimpse of this, to actually later on tonight or the next few weeks to dwell into their website and have a look into a few things that Recover has brought to you, which is basically a set of algorithms and flowcharts that you can follow, where the best medical evidence has been gathered and concluded that these are the steps we need to do to try to get our patients out of the cardiopulmonary arrest. So with that, you're going to have multiple of resources where you're going to have these flowcharts, drug charts, even record sheets, and you even have a mobile that you can use on your normal mobile phones that has a timer, that has a breathing aid, so that you can use in live while you're performing CPR to your patients. And it's completely free, which is the best part of it. With that in things as well for you to take home of being aware and prepared, would you say that you do more than 5 CPRs in a year, more than 10 CPRs in a year? Does anyone would raise their hand towards those numbers? So they don't happen every day, which is good, which is good. But I would advise you to promote within your teams to make some training. First of all, they tend to be quite fun. And as well, it does put your head and your mindset in a way that at any moment this can happen. And the quicker we are in intervening them, the more likely you are to get a return of spontaneous circulation to these patients. So, and it's very easy to forget these things that we don't do it repetitively. So every now and again gathered, you can grab a lovely teddy bear to use as your patient, and you can make this a lot of fun and even improves your teamwork communication in your daily lives. A concept that we will not have time here to go through today, but I just want you to take this home, is having what we would call a crash trolley ready. You don't need to buy something fancy, but you have the concept of having somewhere within your practice, within your clinic, where you have your drugs ready, a set of ET tubes, a set of drugs, even if it's a simple IKEA plastic drawer section where you can have everything labeled and everything ready, set to go. Don't put your coworkers having 10,000 steps done during this process, because you will lose time. And time is of the essence on these patients, because every second that they're deprived of oxygen, the most likely they are to truly die and not to get them back. So just everything in one go. One top tip, for example, instead of having everything inside packages, have your syringe and your needle already attached to each other there to literally grab, draw from the adrenaline vial, and ready to go. nice and simple. As we all know, it's always in moments of rush that Murphy's Law takes over and packages don't open, things go on the floor. So if you have everything ready to go, you will be far more efficient and doing better for the patients. And then what we're just going to go very briefly into is how we communicate these to the carers, and just maybe a few key things on how we can make more sense of something so sudden and so tragic happening to them, and as well the importance of debriefing after each event, or as I like to call it, reflection. So with our carers, I would imagine that a lot of you, when this has happened to you, these will probably be the main questions that come to it. And the first one is, what is wrong with my pet? Especially if they just came through the door. That's usually that type of situation. What I would say in a situation like that is calm and assertive is going to be the best way to help people manage their feelings by knowing some people don't even truly understand what it means that we're doing CPR to them. Because don't forget that medical TV shows made us all believe that everybody gets to live when we go through this, but that's about CPR. So I think someone actually did a study, and about 80% of the patients in fictional, this is actually true, it's about 80% live, which is extraordinary, but that's not the reality of it. So what I would say is, on those moments, the first thing you say to them, especially with a unknown causes, says, we don't know, but we're doing everything we can. And then don't take more than 20 to 30 seconds, and that's already quite a long time, to have someone from the team outside asking, what are your recent medications for your patient and what happened? Because that will help you to quickly do a bit of pattern recognition and possibly aim and target the cause of the arrest of your patient. Either it's your block cat that hasn't peed in 3 days, so you're going to put that hyperkalemia very, very high on the top of your list, or because your diabetic patient, 3 family members just gave the insulin dose, each one at the same time, probably you're going to need to reach from some glucose very, very quickly. And if you want to dwell in some stats, you can discuss with them. This is what we have so far, about 6 to 18% to discharge. And of course, it's much higher in our anesthetic patients. And the reason for that is they are basically fully instrumentalized at that point. And also our mindset is much more ready to start doing CPR to them. But that doesn't mean because of these numbers that we should not do it. A lot of this has to do with the standard of care as well from 10, 15 years ago. And as well as you know, we don't have the pre-hospital setting in the veterinary world as we do in humans with the ambulance and starting CPR on site. But nevertheless, I would continue to strongly continue to do these things to them. And just something, unfortunately, we're not going to have time for this, but it could be quite an interesting topic. You can consider and discuss with them if you suspect, especially for your large breed dogs, or if you suspect either of these other pathologies or you have penetrating thoracic injuries, to go as quickly as possible into open chest CPR. Just then make sure that you either have then the facilities to deal with these patients afterwards, or you have a nearby referral center, such as the Ralph, to deal with these cases. And especially for if you already are in surgery, even if it's abdominal surgery, you can actually, if they do arrest, you can actually get the person who's on the anesthetic machine, starts dealing with this patient's ventilation, and yourselves, whoever is doing the surgery, goes to the diaphragm, makes an incision, hands towards the heart, and you start compressing their hearts, and you start doing CPR, okay? And that will be the best possibility you're gonna give to that patient in that situation. So the importance of diagnosing cardiopulmonary arrests. If you go to the Recover Initiative website, this is the algorithm they come up with, which basically works as a very nice gentle reminder of how to intervene in these cases. But the overall importance of this is, if your patient is unresponsive, 2 things happen. You call for help and you immediately start CPR. There's a query about if you should actually try to check for a pulse for these patients. The answer is just no. In humans, they've studied this. Up to 30 to 40% of very trained doctors and nurses will feel a pulse in a dead person because you feel your own pulse. That is what happens. So if you go into that little cheat sheet and try for 17 minutes, so don't. And it's better for you to go to the unconscious patient, do 1 chest compression. Worst case scenario is going to wake up and look at you. Is this human okay? And then the very best thing, you started the life support of this animal and the only chance of him coming back. So if this happens to you, if he's unresponsive, of course, call for help. This is a teamwork effort without a doubt, but immediately start CPR. And depending on which situation you are in, if you basically you're just on your own, alone, this is the only moment where actually the airways take a bit of priority. Clean those airways, especially if your animal just vomited. You just found your inpatient unconscious with a bit of phlegm in there. Clear that first and then start with your chest compressions. At the same time, you continue to call for help until everyone arrives. And then in the most dream situation, then yes, with two plus team members, first thing to do is chest compressions, chest compressions, chest compressions. You need to take over the function of the heart very, very quickly. Start with that and then get someone to quickly intubate, secure the tube and inflate that tube, because or else this tube will move very, very quickly with those chest compressions. And then as more team members arrive, you can then, of course, also determine your team leader, who gets the IV access, who gets to draw up the drugs, and who as well becomes the scriber, because it does become quite an important role halfway through this process. And my take-home message for you with this, as you start having a lot more cooks, a lot more chefs in the kitchen, use a lot of closed-loop communication. Give the adrenaline. I want this dose of adrenaline given and flush. Always do this back and forth, back and forward. You work as a unit because you now have just become this patient's lifeline. So basically, just to show you, this is the algorithm that has been presented to us in 2024 on how we should manage CPR in our patients. And starting from the beginning, the two key things here, and this is where you should have your team ready to go, is your basic life support and your advanced life support. And the reason for this is your basic life support, which is your chest compressions and ventilation, is going to be the core of everything. And the reason for it is because basically this is actually what's going to maintain oxygen delivery to the tissues. So if you don't have this set to go, everything else that you will do on this side will not do much. So if you have a good step-by-step approach, a good cycle of compressing them and ventilating them, you have about 80% of things running. This here, which is you're monitoring your IV access, reversals, and ongoing drugs, it's basically adjunctive. They're just going to help what you're doing on your basic life support. So this is why we're going to insight a bit more on this one. So starting with your chest compressions, the four key things or in groups to say is 2 full-minute cycles every time before we check if we have a pulse back or not. 2 full minutes. The reason for this is this is what has already been more than experimentally studied, that actually this is when you're going to achieve the maximum of output you're going to get for these patients before we start to fatigue. Doesn't matter if you do CrossFit every day, you will fatigue. And I've done this with both people that go to the gym and not, and even the people that are they will get worse, and sometimes faster than the people they aren't, because this is we all have done it, right? Is this exhausting or not to do? It's exhausting. We get so tired so quickly. We get out of breath with them. So don't try to be a hero. 2 minutes, we check the pulse, swap, because you will do harm to them. Make sure you rotate. And then we're going to go in a bit more detail, the importance of the fact that we deal especially with dogs. It's a species that has a huge variety of sizes and shapes, which of course will determine a lot where we should compress them, how much, the rate, and the importance of recoil. And even so, ladies and gentlemen, experimentally very well executed, external chest compressions only produce 30% of the cardiac output. I don't want to show you this number to put you off of this, but it's just to make you aware that this has to be very well executed to achieve that number and achieve that chance of getting them back, okay? So going through into them, 2-minute cycles, already saw the importance of that, and then compressor rotation and position, which I'm happy just to give you a quick show there, which is basically, I don't know if people will hear me, very easy. Can you still hear me? on the back of the room. So great. So this is Jake. Jake is not feeling great. Jake has just arrested. Someone is calling crash. All of you are coming to my assistance at the same time. Basically, we lock our hands on top of each other. Shoulders above your wrists, elbows locked, and if needed, hopefully, if you have a table that changes the height, even better. If not, no shame in getting a little stool as our level exhibition. Or if needed, if you have something like a St. Bernard or something like that, on the floor is also more than fine. Avoid using your arms to do this. As you can see, I'm all doing nothing. Avoid trying to squat down. This is triple the work, literally on top of them. I need to tippy-toe the table. This is not ideal. And then we literally squeeze repeatedly on top of them. Use the app as your metronomer or sing Staying Alive. It does work, okay? Baby Shark also works. But it can be distracting, to be fair. I've done it. So this is basically the overall shape that you should achieve. Don't be afraid to ask for the table to change. Get some height. Go on the floor. Just make sure that this is sustainable and that we can proceed to do this for the whole of the 2 minutes. And then a few things as well that we need to consider. The chest shape that we have of our patients changes dramatically. And the importance of chest compressions is basically we just took over the job of the heart, right? So we're going to try to compress to make blood flow from the big vessels to the body, to the lungs and the rest of the body. And at the same time, we need to allow for that blood basically to flow back into the heart so it can be ejected. Which means because of the difference of patient, basically conformation, these chests will be very different in the way we are able to compress them, okay? So as a rule of thumb, we will have that our round-chested dog, which is basically our Labradors or Golden Retrievers, they have rounder chests. So if you do try to squeeze them more towards the area of the heart, you're really not doing much. So ideally go more over the dome area. This will increase the intrathoracic pressure and will make blood flow within the heart chambers. And then with our wide-chested dogs, keel-chested, and of course our small dogs and our cats, these are the ones that you do your compressions directly over the heart area. With this, doesn't mean that you need to fixate to these 2 points. As you will see ahead, there's going to be one very good tool to manage that. But just to make you aware that not every single patient you should compress on the same spot. We just need to make aware what's the most efficient to make blood, hopefully, somehow move forward. And don't forget, we're only doing about 30% of it. But the better we do it, the better we achieve that. After our chest compressions, we ventilate. Main ways to get that ventilation going, basically it's your endotracheal intubation. And if you're in a situation that you don't have them, either your tight-fitting mask or mouth to nose can also be achieved. So your endotracheal intubation is your gold standard that hopefully we will have a variety of VT tubes that we can use. Make sure that you have someone quickly intubating these patients and make sure that close to you, you already have tube ties to secure that tube in. With chest compressions, they will move and they will come out, and as well inflate that ET tube. And quickly grab someone very similar to what we have there, an ambu bag to start with oxygen supplementation to quickly start ventilating them. I would strongly also, some people do this as a training, practice sometimes even in your routine surgeries to intubate patients on lateral, which is very different from when we have them standing laryngoscope down on lateral. And for your wide-chested dogs, your brachys, as we already all seen, they were born to be different and to make life difficult at the vet. So therefore, they either are intubated dorsally, because this is how they should be compressed, or you can even try around on lateral and then turn them to dorsal. But use this as your day-to-day practice. It actually will make you far more proficient at these type of intubations that can be tricky to do. And then basically keep that, just make sure that the velocity, again, that app will give you that. Only give one breath every 6 seconds, which is more or less 10 breaths per minute, give or take. The reason for this is if we ventilate them too much, we actually increase the intrathoracic pressure to such a high value that you actually reduce the return of blood towards the heart. So you're going to hinder that cardiac output even further. So try to keep it as low as possible. The app on your phone will help you guide you that. And if you're in a situation that you don't have close by any sort of intubation, you're in the middle of nowhere and you need to perform CPR to an animal that unfortunately just arrested, just make sure that you stretch their necks out, you start chest compressions, and either or you have to go mouth to nose. The only thing is you do 30 chest compressions here, so you eliminate the 2-minute rule. You do 30 chest compressions, stop, you give 2 breaths in, and basically restart. And out. This is very taken from the human world, as we do it with people. If you saw someone collapse, this is the same logic. So it is a bit of mindset. And again, this is just to buy you time until help arrives, or you can bring this animal to the help that he needs. So this is the one part of the whole algorithm that it needs to be in your head: chest compressions and ventilation. Everything else just adds. This is the key one that it needs to be there, and train this over and over again. Going very just briefly to our advanced life support. Basically, this is our monitoring. You only need 2 things. You need an ECG and you need an ETCO2, so basically a capnographer. You can either use your multi-parameter that you use from your anesthetics for either of these equipments. It works beautifully. You don't need to buy any fancy equipment for this. If you want, there are these portable ones that you can use directly in the ET tube. But again, the one that you have on the side is more than enough. And the reason for this is your ECG is going to basically guide your treatment by identifying your rest rhythm, and your capnographer is going to be your best friend at like saying, is the tube in place? Do I need to check it? Is it occluded? Is it out? What happened? And from what we just discussed about the chest compressions is your compression quality. So actually, they do mention about trying to achieve this number of 18 millimeters of mercury, and this is the one that you're going to go, is my rate adequate? Am I pressing on the right point? Is it deep enough? Am I allowing to recoil? Because if you fail on any of these, this number will drop, 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 and sometimes you'll see between compressors this number change. So don't be afraid if this number starts to drop, saying, can you try more to the left? Can you try more over the heart? Shall we go more to the dome? Quicker, slower. Everything can be tweaked by using your capnographer. And then lastly, of course, it is also a very good indication if you have achieved what we call ROSC, which is return of spontaneous circulation. Then it's your IV access. You're all pretty sure more than proficient to it. I don't need to dwell too much into that. You can do a percutaneous. You can just do a quick venous cut down sometimes just because they're perfusing so badly that you can barely see a vein. You've probably all been in this situation where it's very difficult. Or you can even consider it an intraosseous access. When all of this fails, this is one of the scenarios when you can actually consider endotracheal administration. Okay, if we go for this, you don't stop the IV access because of the absorption of the drugs on the airway is still very much unknown. And actually, it's so unknown to the point that what they recommend is literally you can 2 times the dose or 10 times the dose, because the fact is no one knows. So on that note, if you're doing this, still have someone trying to get that IV access. Let's get those drugs into the system. But if you need to do this in the meantime, what you can do is you have a urinary catheter that hopefully is longer than your ET tube. You dilute that volume in saline. You put the catheter down. You put the volume in the catheter with some flush with air, so we make sure that everything goes into the lungs, and we start ventilating again until then the next cycle. Again, this is a very much a plan Z situation, but if it is what you have to do in the meantime, go for it. There might be some drug in the system, enough. You can administer everything down an endotracheal tube except for sodium bicarbonate if at any point you need to give to one of these patients. But everything else, your emergency drugs, your reversals, everything can go down the ET tube. And lastly, of course, especially in our surgery settings, have the reversals stand by on that crash trolley, your flumazenil for your benzos, your naloxone for your opioids, and your antipamazole for your alpha-2 agonists. Just a little point here, some people sometimes will ask you this, should we give steroids, should we give fluids? The answer is very simple, the answer is no, except in very particular situations. So your steroids, actually, they have seen that they do worse in the cases that they have been administered. You can consider in your Addisonian patient on your critically ill related insufficiency corticoids. And your Addisonians, this could be tricky, but if this is more for the patient that you know that is Addisonian. The carers went away for 3 weeks on holiday to Australia. They stopped giving the meds because he was doing so well on it, so there was no need to continue. There we go. So in those situations, you can consider to administer them, but no more than that. And fluids, no, don't forget, it's only 30% of the output. We're going to do more harm than good. The only situation that actually might have a benefit is if you know if it's because they came in with severe hypovolemic shock, massive vomiting and diarrhea, they suffered an RTA, they bled out, so you have a hemoabdomen. These will make sense, a little bolus to get some volume back in, but no more than that. And then we go on basically recognizing the rhythm. We have this going, we pause and check after 2 minutes, and these will be, when you look at your ECG monitor, the 4 rhythms of arrest that you will have. From people who have done CPR, from these 4, what is or are the rhythms that you tend to see more? Do you tend to see a lot of fibrillation or more asystole? What is your feeling? Asystole. Asystole. So in our patient population, it is true that we deal more with asystole and PEA, which is your pulseless electric activity, versus your ventricular fibrillation and your VTAC. How many of you have in their clinics a defibrillator? One? So yeah, it's not something that we tend to use quite a lot, but the truth and the fact is VFib and VTAC are the 2 arrest rhythms that the true treatment for them is defibrillator, okay? There's not more in terms of drugs that we can do. So if you are in that situation, you find any of these rhythms, and this is where the medical shows come to hand, you can actually use the precordial thump. So which is basically you do a very quick and literally blunt force into their chest, because what defibrillation basically does is a very high energy, unsynchronized shock that you give that stops all the electric activity of the heart. So, and that's basically what you're trying to do with these patients. If you use the thump, do it once. Don't carry on doing that. It has very low evidence that it works. You might meet someone in your careers that has done once and they came back to life, but it's very, very, very rare. And then, of course, the ones that we see more, which is our assisted or PE, we basically continue with our chest compression. And we give vasopressors with the aim to basically increase our perfusion towards the heart and towards the brain. So just resuming what we just went through, the animal arrested, we just started with our chest compressions, we started ventilating, we have the monitoring in, we have IV access because everyone is pretty good at IV, we give their reversals, we do the 2-minute cycle, we check for a pulse, check the rhythm, it's going to be your PA or systole, we start giving your vasopressors, which is basically your adrenaline, and then basically that gets repeated every other cycle. The reason why it's every other cycle is the half-life of adrenaline is roughly 3 to 5 minutes, so we really should let it run out before we give the second one to avoid secondary effects from it. And then you can also consider atropine once and very, very early on in your arrest. And this is more if you suspect that might have been vaguely mediated, so that's your severe GI disease because of also ongoing cough, ophthalmological surgery, laryngeal manipulation, and because you gave opioids to the patient. But this is the only one, and only give it once. Don't repeat it. It has a very prolonged half-life, and again, the metabolism of these drugs is going to be very different in these patients, so don't basically give it again. And then basically this is just a cycle that gets repeated itself until hopefully we achieve ROSC or we consider to stop. But what I wanted for you to take home from this is these main points about being prepared for these situations. So don't be afraid to do some practical training at home. Have that crash trolley concept or that crash area ready for these situations. Speak when the carers come, be assertive, be calm. You're trying everything. The situation is dire, but there is a chance. As a team, talk to each other in a calm and assertive form. Allocate roles very, very early. Talk in what we call the closed loop communication and have what we call the silent cockpit. It's very easy for people to start talking in the back in these moments, and which is not adding anything, and you actually lose important information of what has been given if you've done some diagnostics or not what we're doing. So keep this as calm as possible, and every single time that you do this, do a debriefing. And then basically your debriefing is going to be a moment where you're going to, determine some action points towards all of the other process of what you can improve. Did we took too long because we didn't have the equipment ready? Was the capnographer on the other side of the hospital and then someone had to run for it? Did we have these drugs all locked with 5 keys before we had arrived? Think about things that you can do to improve, and as well how you communicate it to each other. And then just to finalize here, as already seen, everyone here has done a certain degree of newborn resuscitation. What is usually the first thing when these little ones land in your hand? What is the first thing that you do to them? Clean the airways. Beautiful. And because of that, the algorithm, we're not going to go in detail for the sake of time, becomes very, very different from the adults. While in the adult patient we prioritize the heart and the chest compression, the key thing on the newborn is ventilation, lung aeration. Don't forget, we've just come from a gas exchange through a vessel via the placenta to suddenly lungs that haven't done much in uterus, to be fair. They're just sitting there. Suddenly, in 5 seconds, they have to expand and do all the work very, very quickly. And that's a shock to the system very, very rapidly. We all have to do that to come to life. So in that scenario, always think, clear the airways. And the key things about this flowchart is literally clear them, check their breathing. If they are already in distress, and that means agonal breathing or cyanotic, you can consider positive pressure ventilation with oxygen and to intubate them very quickly. You should all need to be just aware of their temperature. They don't have regulation centers working just as yet. It's still very primordial. So not on the cold table, but also not on a boiling hot water situation. Either or, we actually already have the numbers for this. They die sooner, so avoid that. Just keep them on a nice steady temperature. It goes from 35 to 37. And then interesting, in these patients, if we think while in the adults that we compress the heart, we use the capnographer as something to tell us your chest compressions are doing very, very well. In these patients, the heartbeat actually is your surrogate for your hypoxemia. So this is an adaptive response that we all have in this phase of life, where the lower the heart rate gets, the lower your oxygen levels go. So it's a bit of a backwards thing if you think about your adults. So it means that while you're cleaning their airways, and if you have started any sort of ventilation on these patients or not, you can look at, they have this golden number here. If above 120, keep them with their mommies, with the nurses, whoever has to take care of them, they're probably fine. But if they're below 120, you can start with a tight-fitting mask to manually ventilate them with oxygen. And you can even at that point, especially in the cesarean scenario, you can start giving them reversals, which, interesting enough, on these little ones, you can even use the sublingual route. Because, of course, intravenous access is very, very difficult. You can try intraosseous catheter, but in a situation of acting there and then and getting them ventilated, you can use the sublingual form. If you listen to their hearts and you are already in a quite marked bradycardia and basically with no heartbeat, you start very similar to what we do in the adult patients, you start your CPR. And this is what it changes. We before did 2 minutes, or if not intubated, we would do 30. Because of the high metabolic rate of these patients, you basically do 4 chest compressions to 1 breath every 2 seconds. This is where you should aim. And the reason why it has to be this fast is every time that you compress these chests, you're also, besides the heart, you're also squeezing their lungs. You're squeezing the organ that clearly has to take over priority above everything else to get them back to life. So very gentle chest compressions. Don't occupy chest cavity as much as you can. Only a third to a half of their chest. Allow recoil. And then literally, this is 1, 2, 3, 4, squeeze, 1, 2, 3, 4, squeeze. This is literally at this speed. And then as a repetitive cycle, what you do is every 30 seconds, you check your heart rate. And it actually can be used to see if you can de-escalate your ventilation or if you just need to continue. And at that point, you need to consider other things as glucose, warming, where you're at, so giving you time to think about what other measures you need to intervene. In the land of the neonates, you can use adrenaline as well, with the same logic every 3 to 4 or 5 minutes. Of course, the timing is a bit different because of the speed you're doing this ventilation. Due to the struggles of IV access, the way to give epinephrine is intranasal. Okay, don't do it sublingual. It will cause a major vasoconstriction to the tongue and they don't absorb it at all. So this one, do it intranasally.